audible now?
Yes, you're audible. Yes, you're audible.
Thank you, Dr. Shubham. So we have come to the last session for today's conference. And it's a very interesting session. We have a debate coming up. Will insulin lose its relevance in the management of type 2 diabetes in the future? To moderate the debate, I would call upon Dr. Somi Goswami. Somi Gupta does not need any introduction further. He has already been introduced. He's a very well-known endocrinologist all over the country. And to co-moderate this session, we have Dr. Rajan Paloi. Dr. Rajan Paloi is a friend and colleague. He's also working with me at Patient Hospital, Durgapur. You can see his CV is uploaded in the screen. Without wasting much of time, I'd like to hand over the proceedings to Dr. Somik to conduct the session. Dr. Somik, please.
Thank you, Dr. Amortha. Very good evening once more. I think it's quite ironic that we have insulin 100 years as our theme, and we have sessions in the evening where we spoke about the past, present, and future of insulin. And now we are talking of whether insulin will lose its relevance in the management of type 2 diabetes in the future. But then again, that is science there for you. Impossible is nothing as far as scientific advancement and the future is concerned. We have an exciting debate topic, and we have two exciting debaters as well. I would just like to put out a small notice in the beginning, which is that since we are running short of time, the rebuttal and the sur-rebuttal, which will be limited to 2 minutes each for each debater. And to introduce our exciting debaters, I have my co-chairperson, Dr. Rajan Paloi. Over to Dr. Paloi to take over the proceedings.
Thank you. Thank you, Dr. Somi Goswami. So for this debate, we have two young endocrinologists here. We have Dr. Sheila Sheikh, who will fight in favor of our topic, that is insulin will lose its relevance in the management of type 2 diabetes in the future. Dr. Sheila Sheikh is a consultant endocrinologist at the Prince Ali Khan Hospital in Mumbai. She has worked for principal investigator for many international clinical trials. She is an executive committee member of the ESI Diabetes India and served for the treasurer and other office bearer for the different scientific committees. Ma'am has many internationally reviewed index paper in the forums. So ma'am is a known face in all over the endocrinology in India. And we have the next speaker slide, please. We have for the against of the motion, we have Dr. Kalyani Sridharan. Kalyani is my senior from JIPMER. She has done from MBBS from Gandhi Medical College and did DM from the JIPMER. She is now working as an assistant professor in AIMS Rishikesh, and she has multiple index publication in national international journals. So without wasting any further time, I will invite Dr. Sheila Sheikh to start her presentation in favor of the topic insulin will lose its relevance in the management of type 2 diabetes mellitus in the future. Over to you, ma'am, please.
Thank you. Thanks for your kind words, and especially thanks for the young part. I love the part where you said, okay, young speakers. So thanks a million. Of course, thanks to the organizers for inviting me to be a part of this meeting. And I know Somik is a hard taskmaster and he's not going to let me go beyond the scheduled time. So I'm going to try my best to stick to time. And I hope, Somik, you're going to actually start the bell now. Okay, so when you're talking about insulin, actually it is ironical that, I am going to be talking about insulin losing its sheen or losing its relevance in the management of type 2 diabetes. Am I going to be talking about the future or am I going to be talking about the present? Before I start telling you anything, I agree that insulin is the discovery of the century. There's no questioning that whatsoever. Many lives saved, many more will continue to be drug of choice in type 1 diabetics, our hospital setups, our acute situations. I am not questioning any of that, mind you. But what I am questioning is this going to be what you and me are going to be prescribing in the future in our OPDs? Is this, if I actually take this a step further, is this what we should be prescribing today in our busy OPDs? Is what is actually something which we all should put our heads together and really ponder and wonder and think that, are we doing justice to our patients? when we are invariably talking in terms of insulin before talking in terms of other injectable agents that are available, or even if I take it further down, oral semaglutide, which is now available. And where has this change come in? Why are we thinking differently? It's almost been a decade when we have become more aware, more cognizant of the fact that, what we as residents, what we always learned was when we were doing our MD was, okay, diabetes is just insulin deficiency vis-a-vis insulin resistance. We've come a long way, friends. And when I say come a long way, indeed, it's been a long way. Discovery of incretin has been a path breaker. Further, discovery of SGLT2 inhibitors has again changed the entire way we look at management of diabetes. And this plethora of molecules, which are giving you much more than only talking in terms of hyperglycemia, have helped you and me personalized treatment as far as our patients are concerned. And when I'm talking about personalized treatment as far as our patients are concerned, you and me are no longer talking only in terms of sugar. We are talking in terms of thinking what kind of cardiovascular, what kind of renal profile your patient is coming to you with. We are talking about multi-targeting. We are talking about combinations of drugs. But we are still stuck somewhere there as far as the thought process goes. Is it inertia? Is it that the thought process is so firmly ingrained that it is only insulin which is going to give you the best efficacy, that we are willing to take the risk of the side effect profile of significant hypoglycemia, which we know is the rate limiting step as far as attainment of target HbA1c is concerned, along with the weight gain? Are we just weighing the pros and cons and saying, okay, the cons are worth the pros? I mean, finally, you're getting your patients to have a better HbA1c without really bothering about the rest of the story. Is that what we are doing? And if that is what we are doing, do we need a change of thought process? Do we need to really realize that as far as efficacy goes, you would be really surprised, because it is actually such a well-ingrained thought process that insulin is the most efficacious molecule as far as diabetes treatment is concerned. But when you look at this very, very elegant meta-analysis, which was actually published as long back as 2016, this shows this was a meta-analysis of short and long-acting GLP-1 receptor agonists versus insulin. What would surprise you is that they cause a greater reduction in A1C than insulin. Not only that, they contribute to weight loss. Not only that, the other issue which you're worried about all the time, lower risk of hypoglycemic episodes. Then why are you and me subjecting our patients to this? Why are we subjecting our patients to an increased risk of hypoglycemia? You would think, okay, maybe this is only at initiation. Maybe this is only when we are initiating an injectable therapy for our patients. But when you're initiating injectable therapy for your patients, you are able to mitigate those two side effects which are all the time worrying. What about intensification? What happens when you want to intensify therapy? How does the scenario really change? You may have basal insulin, for example, in a patient, and you think, no, my patient's post-meal sugars are not doing that well. My fasting is at target and I need to add prandial insulin. Would you add prandial insulin, again creating a number of complications? Or would you think in terms of adding another once a weekly injectable or a daily GLP-1 receptor agonist, which is going to have greater benefit as far as A1C, fasting plasma glucose, and body weight reduction is concerned? I think we ought to rethink. And the reason we ought to rethink is not only because we have a huge amount of data over there, which shows that, yes, even with intensification, our patients are able to do much better when a GLP-1 receptor agonist is added. But not all, what is very important is that our patients need one injection only if it's an FRC. Our patient needs less injections. And when I'm talking about less injection, it does translate into a significant number of lesser pricks as far as your patients are concerned. And that, mind you, friends, does make a difference as far as quality of life goes. The other benefits I've already spoken about. I will not reiterate about that all the time. But yes, it translates into lesser need for monitoring, lesser injections, and improved quality of life. And that makes a very big difference as far as your patient is concerned. Other benefits, we just spoke about CVOTs. We know CVOTs, when you compare GLP-1 receptor agonist with placebo, a whole plethora of trials out there which show that they have the potential to reduce severe CV events. What is interesting is that what the post hoc analysis of 3 major trials This data was presented in the Congress 2020 shows that all strokes are significantly reduced with GLP-1 receptor agonist versus placebo, be which it. So the complications that you worry about all the time in your diabetic patients, these are the molecules which make a difference. This is what you should be using in your patients. You are actually giving your patients, mind you, increased longevity. You are now talking in terms of this patient gaining 3 CVD-free life years with SEMA. And that is huge. You are talking in terms of reducing mortality. I think that's mind-boggling. And why are you not doing it? I really wonder what stops you from doing it. It just is something which you really can't really understand. Why are you subjecting your patients to this increased risk of hypoglycemia? And we know that your patients, most of your patients, especially in our country, maybe 10 years down the line, or we have seen data which say that at least 7 years lag period between your patients actually needing any kind of up titration of medication and actually going on insulin. And those patients are the patients who are going to be at the highest risk of hypoglycemia. When you look across the board, amongst the most frequent causes of severe hypoglycemia is insulin dose miscalculation and insulin. So the writing is up there on the wall. Not only that, this hypoglycemia does translate into a higher mortality. Are you willing to be responsible for that? Is that what we want? Are we not willing to just change our mind process because we believe that no, the best efficacy is going to be with the molecule? What is very interesting is that we always feel that hypoglycemia is seen only as you go lower down the target, as you target, for example, in HbA1c of 6.5 to 7, maybe that's when you will have hypoglycemia. But that's not true. You can have hypoglycemia even with a higher HbA1c across the spectrum. Any diabetic patient on insulin can have hypoglycemia. You would argue that, oh, ma'am, injectable, again, an injectable is going to have a problem. Now, that's the good news. You have oral formulations. You are going to be able to very soon in our country also prescribe an oral long-acting GLP-1 receptor agonist. In the interest of time, I won't go into the details of this. So what would be the best option? Don't you think this would be the best option? A combination of an SGLT2 inhibitor and GLP-1 receptor agonist. And if you're using this kind of combination, where does insulin come in? Where does insulin actually come in? Because when you are using this kind of combination, you are not only able to give your patient good glycemic control, you are able to give your patient a lot more. And that lot more is really a lot more, because you are giving benefit to your patient as far as cardiovascular, as far as kidney, as far as quality of life, as far as mortality, as far as associated morbidity is concerned. And that, mind you, is really huge. And this entire background led to the change in the ADA standards of medical care. Where do you see insulin? At least I tried very hard to understand and see where insulin is in this guidelines, and you would realize that insulins come in only much more down the line. Well, why would that be? If we believe that it is the panacea of, it is the solution for everything, why is it that it is much lower down the line? What is it that does not make insulin come up there? I mean, are the guidelines not right? Are the guidelines, and these are guidelines which are universally changed. You pick up any guideline across the world at this point of time, this is what they are telling you. So we have moved, friends. We have moved. Our decisions, our thought processes, our entire way of looking at our patients with diabetes has changed. We have started optimizing therapy for our patients. We have started recommending therapy which is best suited for our patients, depending on patient-specific factors and comorbidities. We are at this point of time having discussions with our patients and then deciding what we need to do. I know economics always will come in. We would always be worried about economics, but the fact remains that the economics of the molecule, the economics which are associated with the molecule, are mitigated in the long run. What we do not realize, or what we refuse to realize or see, is that we are being penny wise and pound foolish. We are trying to do cost savings when at a point of time when actually it would give you long-term benefit as far as your patient is concerned, and actually save a lot of agony, for your patient, not only in terms of cost, in terms of real health. So yes, I believe that insulin has a beautiful life. It will continue to do so in certain setups. But don't you think it's time we moved on? Don't you think, yes, that's it? It's been a great journey so far, but you need to see the writing on the wall. You need to open those inhibitions. You need to understand that we need to use better molecules. We need to use molecules which would potentially give us lesser side effects. We need to use molecules which would actually help our patients at the end have a long and healthy life. Thank you very, very much. I hope I've stuck to time. Thank you.
Thank you, ma'am. Now I will invite the next speaker who will speak against for the motion, Dr. Kalyani Sridharan. Over to you.
Thank you for the invitation. First, I would like to thank the organizers for having invited me. And Dr. Sheila, that was a very persuasive argument. And thank you very much. I hope I'll make my argument just as persuasive. So I'll just share my screen. Yeah, I hope my screen is visible.
It is, Kalyani.
Yeah. Right. So as you know, I'm talking against this motion that insulin will lose its relevance in the management of type 2 diabetes. So let me first begin from the natural history of type 2 diabetes. As we all know, this is a reiteration of what is very well known. Insulin type 2 diabetes starts with a combination of increased insulin resistance, hyperinsulinemia initially, along with an impaired incretin effect and a slow but progressive beta cell dysfunction, which probably over the years, around 20 to 25 years, which really reaches a level of a complete beta cell failure. So there's no going around this point. This natural history is what it is. So considering this natural history, the way the hyperglycemia progresses just reflects this process. And based again on the same logic of the natural history, the various modalities for treatment for type 2 diabetes so far is one where you replace a deficient hormone, insulin therapy, which is, I agree completely that it is predominantly the case in type 1 diabetes, where the pathophysiology essentially centers around beta cell dysfunction and a beta cell failure very early in the disease onset. However, as Dr. Sheila was just mentioning, in type 2 diabetes, of course, the combination of the increased insulin resistance, the impaired incretin effect, and probably hepatic insulin resistance, the glucose, the glycosuria, these are the various other targets aside from the insulin deficiency, which happens a little later in the disease, which gives you really good targets for oral antidiabetic drugs. And this is probably a scoring point where I again agree that they do offer and should offer significant targets for treatment early on. And the other two modalities remain that where you replace the hormone producing cell, that is the islet cell transplantation or a stem cell therapy, or you replace the entire organ, that's the whole pancreas transplantation. So this basically tells the spectrum of the treatment that's available for diabetes per se. Now, from this, what is the evidence of insulin therapy in type 2 diabetes? Now, again, this is not new. The Origin trial way back in 2012, which was published in the NEJM, talked about use of basal insulin and a cardiovascular benefit. So while insulin has been around for a century, this is probably the first time where it was formally, officially shown that basal insulin is cardiovascular neutral. So basically, it was like a CVOT trials that is an FDA requirement for several other oral antidiabetic drugs. So if you can see here, what they have done is, in addition to the 60% of patients with prior diabetes, they've also taken around 12% of patients with impaired glucose tolerance and impaired fasting glucose with a mean duration of diabetes of just 5 years and a mean A1C of 6.4. And the study conclusion, as you can see from the hazard ratios for their primary outcome, which was a death from cardiovascular causes / non-fatal MI, was that basal insulin glargine had a neutral effect on cardiovascular outcome and no increased effect on cancers, as was the concern before the study. Also, this therapy did maintain a near normal glycemic control. It delayed the progression of dysglycemia. However, I agree that this was associated with a modest increase in hypoglycemic episodes and weight. This is a limiting side effect of any insulin. So this is a nice review that I found where it actually talks about the strength of evidence for the use of starting insulin in type 2 diabetes. So again, it bases most of it on the fact that insulin secretory capacity deteriorates with time. This is supported by strong evidence. Insulin improves the glycemic control and also the obviously the micro and macrovascular complications as shown by the UKPDS study long time back. In addition, of course, there are certain conditions where insulin is mandatory, like patients presenting with diabetic ketoacidosis or patients presenting with hyperglycemia in relation to infection or ischemia, where you would want a prompt glycemic control. So in addition, one interesting point that the study brings out is the hesitancy in starting insulin therapy is not merely the patient hesitancy, it's predominantly the physician hesitancy, where it's just put off thinking it's injectable and we'll just try on adding another drug. But again, in our practice, as you all know, it is not uncommon to find patients still having poor glycemic control after 2 or 3 or even 4 oral drugs. That's absolutely not uncommon. So this again shows a beautiful algorithm where they say what are the various conditions in which insulin requirement is unquestionable, which is at the time of diagnosis, presence of a ketoacidosis, as I said, an acute event like myocardial infarction, perioperatively around the time of surgery, or patients on high dose steroids, like we all saw during the COVID times. And in addition, of course, certain conditions like LADA could be misdiagnosed as type 2 diabetes, and they might require insulin early on. And the later, of course, in a long-standing diabetic patient, the indication remains that the dysglycemia persists even after multiple oral drugs. And to optimize the glycemic control, you are left with no choice but to add insulin in view of the obvious natural history of type 2 diabetes, which is a declining beta cell function. So from the clinical standpoint, for most patients with long-standing diabetes, the question remains from a pragmatic standpoint. It's not should insulin be started, rather it is when and how should insulin be introduced among the drug regimen for the patient for better glycemic control without the adverse effect of hypoglycemia. So will insulin lose its relevance in type 2 diabetes in the future? Absolutely not, at least not in the near future. For the patients with long-standing diabetes, and when I say long-standing, I mean at least 15 to 20 years into type 2 diabetes, insulin will probably remain the only option because that is the only way you're going to replace a deficient hormone. That's the natural history. And in fact, with the newer technology, with the newer innovations in the pump technology, in fact previously it was syringe and vial, and now it's usable pens. It's moving on to pump, and it is moving on to a bionic pancreas and then smart insulins. There are several trials, of course, though not all successful, on inhaled and oral insulins. So with in spite of a century into the discovery of insulin, there is absolutely no limit to the innovations that are being attempted in improving or modifying insulins to circumvent the problem of multiple injections. And with better glucose monitoring, like with the onset of CGMS, I am sure the future is no less bright. That having said that, yes, in early type 2 diabetes, at the very least, if insulin is not the mainstay, I would still say it is an important tool to pick from amongst a basket of choices. And of course, during those specific conditions like ketoacidosis or infection or ischemia, of course, insulin remains an important, probably the only option because of the promptness with which you can get the flexibility with which you can get the sugar control. So what I can conceive is the only condition where exogenous insulin in the current form will lose its relevance is when the technology of islet cell transplant or stem cell therapy becomes the mainstay of management, breaking the current barriers of technicality, feasibility, availability, equity, and cost. And I'm sure that's going to take at least half a century. So maybe that is the future. We are not really sure, but till then, insulin is very, very relevant in the management of type 2 diabetes. it's, as again Dr. Sheila was saying and everyone else is saying, it's 100 years of insulin where we are celebrating it's amazing work in type 1 diabetes. It's you can't replace it in type 1 diabetes. There's no question of that. Even in type 2, with the innovations happening, I don't see it losing its sheen anytime soon. So thank you so much. I'm going to end my talk here and I'll be happy to take any questions.
So both the debaters have done a wonderful job. They have presented their side of the argument with scientific evidence and done it wonderfully, but we still have one last blow remaining before we call it a day. And we first go to Dr. Sheila. You have 2 minutes for the rebuttal.
First of all, Kalyani, thanks for agreeing that, I mean, maybe it may not have relevance in the future. So Kalyani has already said for the motion, as far as I'm concerned, she agreed that yes, we really don't know. Maybe it will lose its sheen in the future. So that's great, first of all. Coming down, I mean, as far as, Kalyani's first slide said that we are talking about beta cell, reduction as far as beta cell function goes. That is one of the pathophysiologies. We now know much more about diabetes. As I said, that is one of the factors which is affected as far as diabetes is concerned. So that is not the only factor as far as the pathophysiology is concerned. As far as cardiovascular effects are concerned, you quoted the Origin study, Kalyani. The Origin study, as far as we all know, and you agreed that it only shows cardiovascular neutrality. So we know that insulin is cardiovascular neutral. It is not giving me any benefit as far as the cardiovascular system is concerned. It is not giving me any benefit as far as the renal system is concerned. It is not giving me any protection from strokes. So again, the issue which is going to arise is that am I justified in using a molecule which is not giving me those benefits vis-a-vis using a molecule with the same efficacy which is going to give me those benefits, and I'm able to reach target. Even in the Origin study, which you quoted, you did mention over there, Kalyani, your slide does say there was an increased risk of hypoglycemia and weight gain. And we all know that hypoglycemia at all points of time has been the Achilles tendon as far as we are concerned when we are managing our patients of diabetes. That's where it's like a doom call for us, because that is what limits our management as far as diabetes is concerned. The highest risk of hypoglycemia, we all agree, whoever's in this board, is that yes, is seen with insulin. Even when you're initiating even the best of insulins, there's nothing like reduced, very, very low level incidence of hypoglycemia, even with whichever generation of insulin you are using. So yes, I would rest my case over here. I stop Soumik. I know how Soumik will others raise the bell, but yes, that's what I want to say.
Again, Dr. Sheila delivers the final blow, and over to Dr. Kalyani for the ultimate blow before we call it a day today.
Yeah, so again, ma'am, I agree with you. The pathogenesis is manifold, but in a long-standing case, it is the beta cell dysfunction is what predominates, and we know that there are many patients who we start on GLP-1, SGLT2, and then they don't maintain the glycemic control. So you eventually, in spite of the hypoglycemic risk, you eventually have to put them on insulin for the glycemic efficacy. So it's not a small number where you can maintain. It's very pragmatically not, I should say, it's not very commonly seen where a patient maintains just on GLP-1 or even a combination of both for like ever. That doesn't just happen. So probably you could delay it and give them the benefit of non-hypoglycemia with these agents, but eventually you ultimately have to put them on insulin. So unless you could probably come up with some smart insulin or glucose censored, where insulin which reduces the risk of hypoglycemia, probably that is the future. Or you could come up with a stem cell or something that actually replaces, then that is the future rather than. And another point that I would like to bring out is the GLP-1. There again is a small set of patients who will not tolerate either of this, both GLP-1 and SGLT2, and then you're left without options, where again you have to put them on insulin. So I agree, in early type 2, yes, it's one among a basket of choices where you actually have to choose based on the pros and cons, the patient profile, patient preferences. But long-standing and those acute conditions, yes, absolutely. Still, I would hold on to saying that, yes, there is a role definitely for insulin. So thank you.
I think with that, we come to the end of this exciting debate. We don't have the logistics for doing a poll or a show of hands, but I think science is the winner. Both the debaters have presented the side of the argument quite well. if I give my personal take, I would say that yes, insulin in the garden variety of patient, possibly as we look at the future, insulin might be pushed even lower down the algorithm, but there would definitely be situations where it would still be the go-to drug in the management of diabetes. So there are points both for and against the motion. With that, I end this part of the program. I thank both the debaters for putting forward an exciting debate over the last 20 or 30 minutes, and I hand it back to Dr. Omorto to call it a day for today's session.
Thanks. Thank you, Soumik.
Thank you. Bye, bye everyone. Good night.
Bye. Thanks, Kalyani. Pleasure debating with you.